Well, thanks very much. I also like to wander around. I'm a little bit hyper, so you're going to have to stick with me. I'm also going to guarantee I'm not going to show you any science. I'm not going to show you any graphs because that's confusing to me. I'm an interventional cardiologist, which means I'm a plumber. So I like to open arteries, and it's fun to do. That's why I do it. We're going to talk about complex coronary interventions. These guys have shown you really great examples of kind of how things happen when they're really simple, when it goes like textbook. But as most of us will tell you, that's unfortunately not the common way to do it. So in terms of complex coronary interventions, I'm going to talk about a couple of things. One is high-risk anatomy and physiology. A second is chronic total occlusions, that these are vessels that have been closed for a long time, and whether or not we should open them up and how we do so. What makes high-risk anatomy and physiology? What makes a patient high risk? Well, there's a couple of things. If it's a left main, which is the most important artery, people hear about us talk about the widowmaker, which is the left anterior descending. The left anterior descending comes off of the left main as it branches. So I refer to the left main as the undertaker. If it's the left main lesion or it's the last remaining vessel that's open, that's a high-risk procedure. If people have severe heart dysfunction already, meaning that their heart is very weak and can't tolerate an insult or any kind of a period of not having enough blood flow, those people are at very high risk. And otherwise, if a patient's not a surgical candidate, if the surgeon's been taking a look at the patient and said, yeah, I don't think so, they kind of scare me, either because they're quite elderly or they have other diseases, bad targets, too many blockages, what have you. So in terms of decreased heart functions, we now have a number of really cool tools. And I've had the great pleasure of practicing during what I like to think of as the golden years of coronary intervention, because companies and smart men and women have brought forth tools and techniques that have made it easier and better to do my job. And one of the things is to work on people with decreased heart functions. In the old days with just balloon angioplasty, this was super high risk and we never did it. Now we have strategies to help us support the heart, to get the heart through the procedure so that we can stent it. And because the heart has to go without blood for a period of time when we're putting a stent in place, because we're plugging the arteries up with our tools. So there are three major tools, and then one particular technique for dealing with really complex branch vessels that I'm going to talk about that has kind of revolutionized what we do. In terms of devices that we've used to help support the heart to get it through the procedure. The old one is the intra-aortic balloon pump, and that's basically a gigantic balloon that inflates and deflates in the aorta. And what that does is it inflates when the heart is filling and it deflates when the heart is squeezing. That makes it easier for the heart to eject the blood. So it's sort of a way of a crutch to support the blood, to support the heart to get the blood out. That's old technology. That's been around for as long as I've been doing this. And as the only gray-haired member of the panel, with the exception of the patient, I can talk a little bit about history. And having one of my high school classmates here with her husband who has a stent, I'm in your group, folks. I'm not in their group anymore. So the next thing that came out was a device that's called an Impella. And this is an amazing device. It actually is an axial pump that goes into the body, and we put it across the aortic valve into the ventricle. And that sucks the blood out of the ventricle and jets it forward, doing the work of the heart. It's an amazing thing. The problem is that it costs $27,000 to $28,000 on a per case basis. So it's very, very expensive, but it is effective. The coolest thing, I think, and this is one of the things that we specialize in, particularly at the Minneapolis Heart Institute, is a thing called ECMO, which means extracorporeal membrane oxygenation. And in that case, we actually take the blood out of the body, send it through a machine. and that machine oxygenates the blood and pumps it back into the body at a higher pressure. So we'll actually be able to bypass the heart in the cath lab while we're working on it. And we do that not only in these high-risk interventional cases, but also the main utility is it for people who are in cardiogenic shock and who are actively having cardiac arrest. And this is an amazing technique that saves a lot of lives. And it only costs about $8,000. So it's a lot less expensive than that Impella, and it has some other additional benefits. But using a combination of these things, we can now get people through their interventions and through their angioplasties and stents that we weren't able to come anywhere near tackling in the past. Another thing I want to talk about is a specialized technique that's been developed that I just think is quite amazing. A lot of times, you know, they showed you these nice pictures, but what happens when a blockage is right at a branch point? How do you stent those branch points there? Companies have tried to make stents that branch, but they're not possible to get them in there because you're putting in a stent from down here or from in here and to get those to work out. So there's a thing that's called the DK crush technique, the double kiss crush technique. And it's a technique to effectively and safely place two overlapping stents at a large branch point, at a bifurcation. And it allows for complete coverage of the disease segments with stent struts, providing a better and a safer long-term result. The things about stents are not only does it makes the procedure safer because it scaffolds the artery open, and it makes it last longer because it holds the artery open, and as Dr. Garcia showed, it has the drugs on it that keep the blockage from coming back. So with these branches, we were really having trouble doing that. And so this is a very complex slide here, but if you look at the upper panel, upper A there, and it shows a blockage at a branch point. And so in this case, we'll actually use two wires and two balloons going down into the arteries at the same time. And this can generally be done through one catheter. Our catheters are big enough, and our tools now are small enough to allow us to do this from just through a little tiny nick in your skin. And we put wires down each place there. We balloon one side, and then we balloon and we balloon the other, and we put a stent in the side branch. Now that stent will stick out into the parent branch a little bit, and then we smash it down, and we go back in and rewire it, and we put two balloons in at the same time and blow them up, and that's kissing balloons. And then we put in E, we put a second stent in there across the first stent in the side branch, blow that up, and then rewire both of those things, and we do another set of balloons once you've got a stent going this way and a stent going this way, because you want to have all of the vessels covered by stent, and you don't want to have any stent struts just hanging out in the middle of the vessel flapping in the breeze. So it's an amazing technique, and it's allowed us to take care of particularly the branching at that undertaker vessel that I talked about, that previously we were unable to deal with in terms of what we could do percutaneously or bicatheter based rather than opening somebody up. The other main area, and this is historically been my area of interest, is chronically occluded vessels. And it's defined as an artery that's been completely occluded for at least 3 months. The problem is that if the downstream heart muscle, because these things can close slowly, or they can close and you can get enough blood supply from other vessels to keep that heart muscle alive. So if the downstream heart muscle doesn't completely die, which it often doesn't, it is always supplied by little tiny bypasses that the body makes called collateral vessels. And this keeps the heart muscle alive. And the problem with those vessels is, while it's enough to keep the heart muscle alive, they're not big enough to improve the blood flow to that segment of the heart muscle when there's an increased need for blood flow, such as with exercise and activity. So And this often results in symptoms. The person's fine when they're just sitting still, but when they do something active, they develop symptoms. And the symptoms I'm talking about are the classic chest discomfort that many people get, but they can also be otherwise, including shortness of breath or exertional fatigue, particularly that don't respond to medications. The first thing we'll do is give you medications to try to make you feel better. If we can't do that, then we need to try to think about how to get more blood down to that part of the heart muscle. The problem is that historically it's been very difficult to open those vessels, and then it's also very hard to keep them open even if you got them open. So, and this was before the advent of this drug-eluting stents. Once we had the drug-eluting stents, now we had a way potentially to keep these chronically occluded vessels open. And we developed new techniques and tools and algorithms to do this. And that leads me to something that we call the hybrid technique. The hybrid technique for CTO PCI, PCI meaning angioplasty, percutaneous intervention. So the main issue in angioplasty is getting a wire past a blockage. And this wire serves as the track to slide balloons and stents down. If you can get a wire past the blockage, you almost always can get a balloon or a stent to follow it. The most common and simplest way to accomplish this is to just advance special wires down through the blockage. That works great. It works the majority of times. In these chronically occluded vessels, however, the wires often can't get through, or they even go offline into the layers of the vessel wall. And so they sort of get down a cul-de-sac and they can't get out. So we can't direct those wires the way we can if you have a 90% blockage. And it takes advantage of kind of two novel considerations for getting the wire past the blockage. It doesn't matter if the wire goes past the blockage by going straight through the middle, which we call the wire escalation technique, so we're just pushing wires down there, or the wire can actually go around the blockage and pop back into the vessel downstream. And that's what we call the dissection reentry technique, where we're just sort of dissecting our way back in there and then re-entering into the true vessel. And it also doesn't matter if the wire follows the normal path of the blood, which is what we call antegrade, so the wire just goes straight down the way of the vessel, or the wire can come through a collateral vessel and then pass the blockage backwards, which is the retrograde technique. And this, a lot of people got together, and Manos was very nice to mention that I was among the people who first took a real interest in doing this. That's true, but a group of us got together and did some cases and talked about it and tried to come up with the best way for dealing with these things. And then we named this the hybrid technique, and Manos was being very kind because he was actually the main author on the paper that described this technique that's really become kind of the standard in the world. Now, I was one of the lesser authors on there, so I got to contribute to it, which basically meant I corrected his grammar. And I was good at that. So here's an example of one of the really cool things that we can do. And this is what I'm talking about, the retrograde, which is the backwards technique. And this is a little hard to follow, but if you look at the panel on the thing on the left, there's a catheter going through there, and then you see the blockage on the right side of the vessel, but we're going into the left coronary artery, and we're going down with a wire through the collateral vessel into the vessel distally. And you can do three things with that. We can use that as a marker to tell us where to go when we're trying to get downstream. Sometimes we can just, sometimes we can actually get the wire to go through backwards by itself and just come out. Or we meet in the middle and bring the wire out. And so what you end up with is a wire that comes down this catheter through that native healthy vessel, down through a collateral vessel, back up through the blockage, and then back up into the other catheter. We keep pushing on that wire, and it basically comes out the other end of the catheter. So you have a wire that's going in, and classically it would go in one leg, up to the heart, through the heart muscle, up to the other vessel, backwards through the other vessel, into a catheter, and out through the other leg. Literally a flossing type of technique. When I first saw this done, and this was actually developed by Japanese operators 12, 15 years ago. When I first saw this done at a conference, I was absolutely dumbfounded. So this is an example of that technique. Now, you can see here that there should have been this vessel here that came down, but that's completely occluded. If you look through the other vessel, you can see it filling late over on the far right-hand side of the screen. That's through those collateral vessels. This was an attempt to go down Antegrade, or to go down the regular stream here, but the wire goes offline, and we can't get there. And we tried for quite a while, and we couldn't get there, so we went backwards. If you look here at that right coronary artery, you can see those little bypasses that have grown in there, those tiny little vessels that then fill out this big vessel here. So we try to advance wires down through that, through our little catheter, with our little catheters, and get that wire to go back up and then upstream into that vessel. And then we meet in the middle. And if you watch here on this, you'll see that there's a wire kind of here in the middle, and we're inflating a balloon up in here. We deflate it to create a space, and then we'll advance the wire, and the wire pops out there. And so once we get the wire out there, we know we can grab that wire and use that as the rail to get our balloons down. So we're flossing people. This is, once the wire is then up, we can use that to advance balloons down, and that's what that is there. You see a balloon being inflated in that occlusion. And this is what that vessel looks like when we're done. The one going down, which you couldn't see at all before, is completely open now. The other thing that has been developed is, and this is a cool thing, and Manos and I both were able to be part of this original research, and this was actually a Minneapolis-based company called Bridgepoint Medical, and they developed a technique for going down past the blockage, and if you end up in the side of the vessel, how to get back into the good, healthy vessel downstream. They developed a catheter called a cross-boss that helps us get past the blockage. This will go down into the wall of the vessel a lot of the time, that cul-de-sac that I discussed, but we'll leave a wire there through that. And then we come down with a very specialized balloon, and it's a flat balloon. It's not a rounded balloon, so that when it gets inflated, it flattens out, and that's why it's called the Stingray. Everybody's about very clever names, and you can tell, if it's done correctly, which way the balloon is oriented relative to the place you want the wire to be. And they've got a specialized wire, and they've got two different places where the wire can come out. And if it's coming out the right direction, it can pop through into the good part of the vessel downstream. Then you remove that, and over that wire, then you pass a regular balloon and stent that vessel. And this is an example of that. This is a right coronary artery that's completely occluded, and it's a very short occlusion. We should be able to, you'd think you'd be able to get through this with a wire real easily and just, bing, bang, boom, be done. And that was what was initially done here. This wire was taken down here. It looks great. We're thinking, hey, looks like we got a pretty good shot here. But if you look at that picture, at that artery from another view here, you can see that the tip of the wire is actually not inside the vessel. It's alongside the vessel. And that hasn't gotten us. It's like if your car runs off in the ditch. You got to get back out of the ditch. And this wire is in the ditch. So you use the Stingray balloon, and you can see that inflated right here. And then through the Stingray balloon, we'll pass a wire, and you see how that wire is sticking out the side of the balloon there? That's getting into what we hope to be the correct spot. And you'll see that wire advance down a little bit there, and it is going into the true vessel. So after that, we get the wire all the way down, and this is what the vessel looks like when we're done. So that's it. I just get to show cool stuff. So thanks.